Friends, I think most of us know very well Dr. Ramneek Mahajan. He has delivered 2-3 times lecture in our forum, and he is at present senior director and at Max Smart Hospital Sake, Department of Orthopedic, and also head of the Joint Replacement Unit, me and him. He has a unique record of doing highest robotic surgery in Delhi, orthopedics. And he MCH and MS in orthopedic. Everybody, I think, must have gone to him or with his relative or friend for surgery, for advice. So I request Dr. Ramneek Mahajan to start role of robotic in joint replacement. Just one word from my side: robotic means more precision, precision, precision. So surgery is still being done by the surgeon, but the robotic part helps in more precision of the surgery. Over to Ramneek Mahajan.
Okay. Good evening, friends. Thank you, Dr. Chauhan. Thank you, team. 868 is a big number. I definitely have participated in quite a few of those. Since I landed in Delhi, I've been in Delhi since 2003. So, as I said, and I've always come to this forum and I always have shared a lot of talks on orthopedics. I started with, I think my first talk was on just a simple topic like osteoporosis, followed by joint replacements, navigation, knee replacements. We even did a live surgery relay when we were at Nova, so people were there and all those things. So this time when we discussed, I thought we have spoken on everything, but there is something very exclusive and unique that is only available with us. And that is use of robotics in hip replacements. There are many robots, and last time also I had shared the types of robots and what everything is there. But this is very unique. That is robotics in hip replacement, and that is there available at Max Hospital. So when I say robotics, what do you mean by robotics in it? This is the robot. The word says it all, it's personalized system. This machine, the patient comes, patient gets his CD scans, and these CD scans are sent to a lab in the US. So this lab takes 24 hours to give us this kind of a plan. On this plan, if you see on the bottom right and on the bottom top, how it is already pre-decided that this patient, the perfect fit would be at this angle, and if we are able to achieve that, the limb length will be equal, and we will have a combined offsets and all those things, so that is more precision. Then the robot needs to know the patient. So on the patient, when you are operating, you must start marking these points. These points are registered by the computer. Once the computer has registered the femur head, the acetabulum, these bubbles we place our probe on these bubbles. These bubbles, if they become white, that says that your registration is accurate. And when I mean by accurate, it is less than 0.5 millimeters. Then this is the robotic arm. This is held by the surgeon. The surgeon is right there holding the robotic arm, then placing the implant. This is when you are reaming, and you can see on the right side that the robot actually helps us in clearing at the right angle. Once that is done, then the robotic arm has the implant attached to it, and the surgeon drives it in. If the surgeon is driving it in, then how is it robotic? Because the robot is locked. You cannot even push the robot forward, backwards, up or down. That's how locked it is. And once that is done, you know that your job is done. So that is what this robotic does. So So if this is what I wanted to explain to you, my talk is over. So this is, you know, that is robotics. But then the question comes starting from this. I remember in the last talk also when I spoke on knee, and the question was, who performs this surgery? Surgery is still performed by the surgeon. It still needs knee, so I have to hold it in my arm. If I don't hold it, it cannot move. That's the difference. Not like this, which Dr. Poddar, you know, you do it, and that is robotic in your GI surgery. When the robo is working, patient and robo are dealing with each other, and the surgeon is sitting at the back, sitting on the console. That is not what is robotics in orthopedics, whether it is hip replacement, knee replacement, or partial knee replacement. The surgeon, that is me, I am driving it, and see, when I say it is locked in such a manner that when I am holding it in, it is in my arm, but my eyes are looking at the monitor on that green platform. So that when the robo will move, it will move into that sphere, clear of the green, and you are ready to operate. So then the person says, my robot is better than yours. A lot of people come in and ongoing debate. This particular platform kills that debate, because no other manufacturer or any other robo can do a hip replacement. All across the world, if you want a robotic hip replacement, then the only robo available is this one. That's available with us at Max Hospital, sir. So we got it last year, and we have now crossed 500 with this in last 1 year. So that is only the robotic surgeries in last 1 year with this particular system. But then why do I need robots? I've been doing a hip replacement now for 24 years. There are so many patients who have been touched left, right, center. Then why do I need a robotic? I need a robotic to take care of those outliers in my practice. So what is the first problem that somebody says? The problem is, I have heard of a patient who did a hip replacement. Their hip gets dislocated. It keeps popping out. Somebody says, I've got a hip replacement, but दोनों leg बराबर नहीं है. The length is not proper. Somebody says, everything is fine, but the limp has not gone. So many things. The myth with hip replacements was the major issue. या तो length बराबर नहीं होगी, या limp नहीं आएगा, या dislocate होता रहेगा. So you will never be comfortable in doing your activities. So we as surgeons used to plan. How do we plan? On an X-ray, this is an X-ray, and we would want our hip or cup to sit at this level. So once the calculation is done, I will take you through a story now. A 37-year-old male. If I am doing this patient's right hip surgery and I don't have a robotic, I will take this X-ray. On this X-ray, I will draw these lines so that I need to know how much is the lengthening or the shortening. Once I draw these lines, I would calculate where the center should be depending on my lines, angles, and I would decide that this probably looks like the cup, where the cup should sit. Can I put the cup there? So I will need my mathematical calculations. This is where an orthopedic surgeon starts going into maths. And why does he go into maths? He needs more perfection. When I look at this and I say, this is how then I calculate. So these are some templates. We start putting them on the hip joint. And once we put them on the hip joint, we decide that the cup will be here. Once we are sure with what we want, we thought we will go in. And how will the execution happen? The execution is still happening with my planning. So that means if my planning is wrong on first stage, everything will go wrong. Then to execute that position for the cup means eyeballing. You really don't know, you have some gadgets, you start looking at it, you put your cup in like this and you start calculating this is 45 degrees. but you still don't know whether you need 45 or what you need for this patient. Then we started using navigations. So when I started using navigation in 2012, we had this plan with us. This is called TraumaCAD, also only available at Max Hospital now, since 2014. So with this, we realized we would do the same amount of planning, find the same gadget for this patient and the same orientations, do our calculations now with computers, and once we had this plan ready for us, for this patient, we would know this is the cup, this is the stem, everything is already decided that this would be the fit, but the execution is still me, the surgeon, the man behind the machine. Sir, good evening. So, before the surgery itself, we would have this plan ready for this patient, that this is the decision done. But then why would problems happen? Because there was still a problem either in calculations or in executions. And we were always dependent on the X-rays provided by the lab. And then those X-rays would come either small, large. We would say we need 120% magnification. Then my templates would fit and give me a size. But you'd never know 120 is 120 or 120 is 130 or 125. Then we always used to struggle. So then we got hold of robotics and see what the robotic platform does for us. It tells us for this particular, so now this is, mind you, the same patient. So we have done the calculation for this presentation, all three platforms, to find out how this platform is beneficial, that when I'm looking at it, I know how much the limb would be short, how much the limb would be long, and even before the surgery, we would know that the hip would sit like this. That means we will be able to execute it to this perfection, that before the surgery we know that if I use this size stem 6, this 127 with a 0 head, and I will still get the same result that I want. And once I know, I also know that my cup will sit like this. I can change the position of the cup. I can change the position of the orientation of the angle, and it becomes so different. How to calculate those angles? So this robotic platform with the CT based helps us in this calculation. Once we know this calculation, see on the bottom right, it says supine when the patient is lying down, in standing position and in sitting position. That means when the patient from lying down position stands and walks, will it dislocate? Why? Because the normal tendency of my hip joint is that from a lying down position, when I stand, my socket opens up because my spine goes back. And if I have a flexible spine, it moves. And look at me, I'm aging, you are senior to me, you have probably more degeneration in your spine. I do a hip replacement, and after 5 years, patient was doing fine, 6th year he lands into the OPD with a dislocated hip. What is the reason? He had gone to a spine surgeon, he had a disc problem, they operated his disc, fused his spine, the movements of the spine changed, and when the movements of the spine changed, he started dislocating his hip, so which was doing very well. So this right side is actually helping us in taking those into account so that he doesn't dislocate. So when you start looking at it, you realize that the cup sits in this fashion, the X-ray would look like this, and once these things happen, the parameters will change. His combined version is 42. When he stands, from a lying down position of 32, his pelvis changes to 42. His pelvis changes to 59 when he sits. So all these movements might dislocate. So then you start playing around and changing the angles, and look at that, that is the sacral slope. We calculate how his spine angles are. Then these spine angles are feeded, and you know the sacral slope is 11, so the pelvic tilt is 25. So this patient would need that also to be incorporated. That is what is called the spine balance with the hip. So once that is done, you know, if I execute it to perfection, look at my limb length, it will be 0. And now look at this left side. You see the right side? The hip is moving. This is in the robotic platform. We do all movements that this patient might do in his lifetime. पूरा पैर खोल लेगा, डांस करेगा, ऊपर जाएगा, नीचे आएगा, स्क्वाट करेगा, नील करेगा. All these movements are happening at different angles. And with these movements, will he dislocate? He is not dislocating, he is not impinging. So when you know all these parameters, you would say, these angles will be the best for this patient, these sizes will be the best. Now, all said and done, he is not impinging, he is not, so he will not dislocate. And this is the execution. After the robotic, you get the same angles with the limb length achieved, the offset achieved. Another patient, again you can see here, he has problems in both the hips. He has his hips, pelvis spine issues. Again you start the same way, you calculate, you know that right now he is 2 millimeters short as compared to the left side, but I have to operate the left also. So that means I have to plan that I will operate the right in such a way that when I come back and operate his left after 1 year, 2 years, whenever he is ready, I have some data on which I can proceed. Otherwise, I operate without a data. How will I remember after 2 hours what did I do for this patient? And I have no calculations. I do not know the muscle tension. What will I reproduce after 2 years? Nothing. So, how this helps, that you plan. Once you plan for this patient, again the same way, you plan everything, how he sits, how he stands, what happens to his spine during this, and you end up lengthening him by 3 millimeters, so that next time when he comes back, I have to achieve 3 millimeters, because that is the perfect for the left hip. So we have actually planned for the future by doing the right hip today and lengthening him by 3 millimeters for the same. A mind does not perceive what is 3 millimeters. 3 millimeters, just imagine, is hardly this much. Like an insole of a shoe is probably 3 millimeters or slightly less. But अगर हमारे पैर के अंदर एक छोटा सा कंकड़ भी आ जाए, we find it difficult to negotiate ourselves. So that is what you're trying to achieve with this. So this was the plan, this was the angles, and you see now we start moving and you will find that he starts to impinge. That red zone that you see means he is impinging. So that 40-15 which is there will probably need to be changed so that he does not dislocate, otherwise he will pop out. So with this you also know where he is impinging. Here he might just pop out, and you might change those angles of 40 and 15 so that he will not impinge. So once you know where, you would end up with a 40 and 20, and you can still see there is still some impingement, you reduce, and 16 is the right number for him. So this cup will go at 40 degrees of inclination, 16 degrees of version, and then this patient will not dislocate. So you're talking of 3 or 4 degrees to achieve that best fit for this patient so that he doesn't dislocate in all the daily movements, and that's the execution exactly the same way as you had planned. So that is what I just explained to you. I will not go into the videos, but see how it helps. You plan for a 40-15, you end up with a 40-15, a margin of 1 degrees. This is after you've done the surgery, and that is how you end up. And look at the limb length. You know that you have equalized the leg for this patient. You have reduced his offset for 4 degrees because he was going out, he was hitting and getting a trochanter bursitis. You have reduced that so that again he starts feeling better. To a point, that's the same which I was trying to explain of how we do it. This is just a small video, I will not run the whole video. So this is how you are calculating, but look at what you are doing for this patient. All these things of 3, 4 will keep changing when I keep changing the right numbers for this patient. Keep adding numbers to it, you keep adding positions to the cup, you keep adding how he stands, how he sits, add spine movements, and you can see on the scroll now, whatever is happening on the transverse view, you can also see it, how he will look in from the front, where the cup would sit, will he be inside the bone, will he be coming outside the bone. So all those kinds of plans, that's the margin of the bone, the pelvis, that's the acetabular margin, that's how the cup would sit, and you can then play around on all these numbers. You can keep moving around, keep juggling, and now this is the stem. You also know that the stem should sit in the center, it will not hit the bone. If it is touching the bone, you can rotate from here. It has to be this much only exposed. That means from a posterior entry point, it has to expose, and look at this number. When I change how this stem moves. And look at this number, -2, means this patient was born with a deformity which is called retroversion. Normally we have a tendency to stand with anteversion, looking forward. This patient had a -2 degrees of retroversion. He was born with looking back. So we had to correct that also and take that also into consideration. This is that retroversion. So you put the stem in 17 degrees of version and you are making him 1 mm longer. That is where it helps us, and the moment you change the size, it becomes equal. So you do not leave him with a length. Once you can adjust and play around with either the position of the stem, the position of the cup, the size of the head, how much you need to go inside the bone or how much you need to come out, so that you can either shorten or lengthen or take him out or bring him in. And that's where the execution would look like. I will not take you to the detailed surgery. I recorded this surgery a couple of days back. For this presentation, I first thought I might just show the surgery. But I thought it will not be of that much interest. But what we do with robotics would be of more interest. So I will run fast through this surgery. You cut open, you go in, all those are planned. So see, you need the surgeon. Robo is not doing anything. Robo is only my friend and a guide. So that means, in a layman language, if I might say in this forum, if the driver does not know how to read that Google map, when there is a diversion happening, he will go under the flyover instead when he had to go over the flyover. So that is where the robotic also needs that particular mind to understand the computer part of it, the science, the physics or the mathematics part of it, to calculate those angles to that perfection. Once your calculation is okay, then you don't need this surgery part, you just go in and look at the cup now. So that's where the pins are, that's where your cup are, and look at on the right side now. Those are checkpoints. Now I'm executing the surgery. So when I am executing the surgery, those checkpoints will tell us that we never deviate. So during the process of surgery, you keep going back, putting your probe on the checkpoint. Computer tells us that you are less than 0.5 millimeters. There comes a green tick, and once that green tick comes, you can proceed, otherwise you cannot proceed. Once that is done, see, those are, now I hold the reamer in my hand, bring the reamer in. Once I tell them, look at that right side yellow, that yellow will become green, that tick mark comes up. Now, once that is done, only then the surgery will proceed. The cup size is already fed there. That is the reamer side which is going in. I hold it and now I will be pushing it in. Once the computer knows and I have a clear vision of where I am going. Once I go in and I have that green tick, look at that right boundary. It reams around, takes that green out. So that is the bone that is taken out, and once it is done, it's all white. That means my reaming is done at that particular angles which I wanted. So once those bed is created, the word is press fit. Press fit means that in this cup which has been reamed to 49, I can hammer in a 50 millimeter cup. So once that goes in, it locks, it will not move. That is what you mean by press fit, that I can actually sit and rock the whole patient, the cup is locked inside. So once that is done, once you are ready with the surgery part, you bring the cup in. And once you bring the cup in, you can just hammer the cup inside. With the robot again in my hand, you can just hammer it in, and that will look at the cup going in. That's the position that you would have. And see now, final trimming, again for the principle that we wanted to do, and that's now the cup coming in. You can see I'm rocking that whole thing up and it is not moving. The whole patient has been jammed. The robot does not allow me to move anywhere. I can push it forward, I can bring it back. It is locked at 41/16. So I wanted to start and give this patient a 41 inclination, a 16 version. And once I am moving, it just doesn't move. It's so solid there. And once it is done, sorry. So once it is done, that's the stem. You again take the stem. Again I am going in. I am holding it in my hand. Once I plan for the stem, I take the stem in. I put the necessary head, I reduce the hip, and once that is done, you see, it starts telling you that you wanted a 5 millimeter difference, you have your 5 millimeter there. It has come back to exactly where you wanted to execute. You can see 5 and 5, so both have matched each other. And once that is done, now you start looking at 4 and 4. It even tells you how much you have lengthened or shortened to a point that is how you read now, that you ended up with a 3 and 3. So that is what is your robotic system in hip replacement. This was the patient that we were discussing, a young girl, 34 years old, and this patient got her both hip replacements done on the same day. We are going through a epidemic at this moment, post-COVID, and patients, even young, old, they are coming back. They were given steroids, but those were necessary at that time to save their life. Now they are coming back with something called avascular necrosis. The youngest that we have operated is 14 years old with a hip, and the oldest that we have operated very recently is 96 years old. Very good. So the thing is, what is happening is, the avascular necrosis which is coming back because of COVID and steroids, that's an epidemic that we are going through. And this girl got her both hip replaced on the same day. This is a success story which is there on the Max website. I will not go much into the details of it. That you just saw her surgery, you just saw her x-rays. So she was wheelchair bound and she's just joined back. She came from Mumbai, works in the film industry, and she has joined back her, and she is coming into a senior very soon. Very good. That's Nikita. Thank you so much. That was it for today.
Thank you, Dr. Ramneek. I think we all agree that this was an excellent lecture on the role of robotics in hip replacement. And basically, again, I will say it adds to the precision of the surgery. As I said earlier also, surgery is still being done by the surgeon. Robot only help precision, how much to cut, angle, where to be fitted, like that. My only question is, when robots were not available, in how many percent of cases you felt this problem of shortening or something which required another surgery?
10%. A shortening or a lengthening does not need another surgery. The only thing is you need then shoe raise up or shoe raise down. Another surgeries or revision surgeries were required when the hips were dislocating. The risk of dislocation, sir, is less than 1%. But when you start adding dislocations, you start adding limb lengths, you start adding instability to 5%. But if they are even 2 to 5% my practice, for me it is a census. 100 में 2. But for you as a patient it is 100 out of 100. So then if you have a technology which can take care of those outliers, the word here is not only precision, the word here is execution. Let me tell you, I was very precise. My calculations, I am on the faculty board. I was very recently in Singapore General Hospital teaching there about what I just showed you, the planning part of it. So, but my concern here is I can plan well, I can execute well, but there might come up one patient where I am not able to execute. That patient could be me, that patient could be you, that patient could be somebody we know. So with the help of technology, I can also execute my planning. So if I can execute my planning to that precision, that is what I want.
Thank you. Now it's open to questions from the.
What is the lifespan?
Sir, this is a technology. It's not lifespan. Lifespan is for a hip replacement as such. I am in practice now for 25 years. I had my learning phase, teaching. So I still have those patients who I operated 25 years back as a follow-up to me. They are not failing. The problem is not the lifespan, sir. The problem is how I use my car. If I have a patient, I know a patient, he goes for trekking, hiking. The other day, I can show you on my laptop, I have a presentation where this girl we operated last year did paragliding and jumping from an aeroplane. So the problem is if you misuse your hip, you will fail early. Otherwise you don't.
What's the cost?
Cost for this robotic technology, the hospital.
How much it costs extra if you use the robot?
60,000 rupees extra is what the hospital is
Extra
charging.
than other open surgery.
From a routine surgery, adds 60,000 rupees. But that 60,000 includes 34,000 rupees worth of disposable. Because I cannot use the same trackers, the same probes which I have used on you. I have to use a separate set. So if I use a disposable worth of 34, I think hospital is allowed, justified to make 26 extra.
Insurance company pays for it.
Insurance companies do not pay for robotics.
Now they are coming up.
Sir, all the insurance companies who were paying, some of them who were paying, they have also stopped paying now.
General surgery, they pay up to 2 lakhs.
So that's what they say.
After 2 lakhs, they will not.
That's what they say, that there is an upper limit ceiling of some companies say 1 lakh, some companies say 2 lakh. If you want to do robotic, you do. We will only pay you 1 lakh. और bill तो 4.5-5 का बनेगा. Rest is yours.
Dr. Ramneek, we have Dr. Raj from ESI Basai Dharapur. He is an orthopedic guy. He wants to ask a question.
Sir, good evening, sir. Sir, do you use other approaches for operating him?
So now approaches, you know, orthopedic surgery you asking me. All my approaches are anterolateral.
All? Even revisions?
Everything, 100%. So I get people from many PSs who do fellowships with me. We always have, right now also have 2 fellows. They only come for this. You don't need to change the way you drive your car. The robotic actually does not change from what you are doing. It only adds more precision. Forget about robotics. You are a junior, so I'll just tell you. Learn one and become the master of that. You don't need anyone else. Today you do posterior, tomorrow you do anterolateral. Now the new baby DAA. Okay? I do DAA if I need to. So if I get a VIP patient coming from Canada or US, they want DAA. That's the fad in their country. So just run DAA for them. But that does not mean that I need to, because if you keep changing in your mass, you're jack of all trades but master of none. And I can tell you, even 5 times revised hip, I have done with the same approach, I have not changed.
Thanks.
Yeah,
said for future planning, we were leaving a gap of 3 millimeters. We were leaving a gap of 3 millimeters in case the patient decides for the second. If the patient doesn't decide, like we said, thoda sa कंकड़ भी disturb करता है. Will that 3 millimeter disturb him?
No, he just has to add an insole in the other shoe. But then he has to live with pain on that.
Sir, there was a concern of the cobalt leak in, and one of the hip was earlier recalled by
That was ASR cup.
big company.
That was ASR and BSR, PHR cups. That was metal on metal.
Right. So,
That is
but the newer hips, there's never a concern with these.
Metal on metal was a fad. And it is today also. Don't run for fads. Metal on metal was a fad. So if, let's say, you and I have seen what happened with Xerox and Kodak. No company wants a Kodak moment, so they keep bringing in new. That does not mean the older generation was bad. Do you think I used to drive a Santro at one point of time? I was very happy with Santro. Even yesterday I was talking to my wife, "Koi gaadi वापस ले लेते, इसको बेची थी." For my daughter, we want a car. Now she's learning. Models don't run with fads. That metal on metal was one outlier. After that, everything is the same.
Now it's metal on ceramic mostly.
This is the ceramic on ceramic and ceramic on poly. Metal on poly, we have everything. See, the thing is, I need to drink my tea. जितना मीठा पीना उतना चम्मच. Sir asked, कितना चलेगा? If you use, I have multiple options available as per evidence-based medicine, as per literature and data. The ceramic on ceramic, followed by ceramic on a highly cross-linked polyethylene, is the go-to gold standards, which are doing well. But then they are expensive. See, then the patient chooses as per his pocket. That does not mean a metal on a poly is bad. 25 years people used to do metal on poly. They are still doing well. So it's not that they are bad, but if I am sitting here and given a choice, I would always choose an iPhone 15 over an iPhone 13. That's the same thing. So price or everything changes depends on what you expect out of it. If you have a 94-year-old gentleman who just operated 2 days back, you mean to say I would have done a titanium hip on him? I did not do a titanium hip on him because that is the base. Titanium is going to last him for 30 years. I don't expect that uncle God give him long life. But at 94, asking him to spend 2,50,000 rupees worth on an implant, I would be the most foolish person. I have done only 85,000 rupees worth of an implant on him. Why do I need him to spend more money? So we also need to choose what will work for him. What is his lifespan? And then we choose our implants as well.
Hello. Yes, sir. Sir, Nabi, sir, I have one question. Sir, what about synovial fluid? Sir, आपने change कर दिया आपने बोल को तो replace कर दिया. Synovial fluid का क्या करेंगे? उसकी synovial membrane को change करेंगे क्या करेंगे? फिर वो तो friction बहुत ज़्यादा होगा, आवाज आएगी.
क्यों आएगी? Synovial fluid तो वहाँ पे पूरा synovial hypertrophy बहुत बड़ा synovial तो वहीं पड़ा. Synovial तो वहीं पड़ा. हमने तो cartilage change किया. Synovial तो वहीं पड़ा. Synovium तो covering है. Synovium is your covering like a grass. हमने तो synovium को तो कुछ किया ही नहीं. हमने तो cartilage को छेड़ दिया. Cartilage को नया cartilage दे दिया. Like दीवार का POP.
सर कुछ पेशेंट हमारे पास आते हैं कि आपका फ्लूइड कम हो गया, synovial fluid कम हो गया.
Those are arthritic patients. They who get arthritis, तो fluid कम हो गया does not mean कि उनको arthritis हो गया. तो हमने एक ligament कम पकड़ा हुआ है. वही arthritis के patient जिनको हम कहते हैं कि तुम्हारा fluid कम हो गया, वो इतनी बड़ी swelling यहाँ लेके आ जाते हैं. Broad, वो क्या है? वो सारा synovial fluid ही तो है. It's not.
और सर ग्लूकोजामाइन हमारे पास बहुत सारे पेशेंट आते हैं, ग्लूकोजामाइन हम प्रिस्क्राइब करते हैं उनको फ्री से.
American Academy of Orthopedic Surgeons guidelines says it's a sham. It's a placebo, it's a sham. So guidelines में कहीं नहीं लिखा. It's तभी उसके लिए उसके ऊपर word लिखा है dietary supplement और जो government doctors हैं वो refer भी नहीं करते उसके पैसे.
Now, alcoholic atrophy of the femur head. How often do you see that?
Which one?
Alcoholic.
Which A and D? Alcohol it's very common. So the avascular necrosis that we said, 50% is idiopathic. where you don't know the cause. After that, it is alcohol and steroids.
Okay. Thank you.
I am not taking you away from your glass, by the way.
Sir, my question is it invariably him shortening in hip consonant?
No. No.
But I have seen some patients which have got just recently shortening.
Sir,
What is the cause? And what is the cause then?
Cause is your planning. Whoever was operating his planning and his execution. If his planning was good,
Otherwise there should no
ideally, you don't want lengthening or shortening. You want equal lengths.
Yes, sir.
There are instances where I choose to leave your length either 2 millimeters longer or 2 millimeters shorter. That is when I choose, when I tell you before your surgery.
Sir,
The reason is, the
cause of that?
The reason is, where do you get your length from? From a rubber band. What is the rubber band? The muscles. Now you have chronic fibrosis. You have not done your hip surgery, which you should have done 30 years back. 30 years you kept sitting on that hip, so the whole muscles have become fibrotic, and then you try to put in the hip, and when how will that muscle expand? So you can choose between two. Either accept a hip which dislocates, or accept shortening. What will you choose? That's what we tell the patient. That is why in our OPD, we never promise length. We always say that we will try to achieve length, but it also is subject to what you have come back with. If you have come with a very shortened muscle, thickened, fibrotic, I cannot cut it beyond the fibrotic band.
Thank you, sir.
Friends, as I would request Dr. Tulsi and Dr. Kalra sir to wind it up in 5 minutes, because
Last question can you ask?
just a minute, sir, just a minute, to felicitate Dr. Tyagi sir. So just in 5 minutes.
What a wonderful talk, Dr. Ramneek, as usual. So, Dr. Poddar dwelt about the implants. So, is it the MOM? Is it the metal on polyethylene? Or is it the COC, which is the ceramic on ceramic? What do you prefer, sir?
Ceramic or poly? Highly cross-linked poly.
Ceramic?
Or highly cross-linked poly.
Right, so that seems to be the choice today. Any concerns about metallosis and pseudotumors, which is present about 29% if you use MOM?
MOM is not used nowadays, sir, it is obsolete.
So why are we using this in knee replacements?
We are not using MOM in knee.
No longer in knee replacements?
We have never used MOM in knee replacement.
Knee replacements? Ceramic on ceramic?
No, it is metal, then a polyethylene in between, and then a metal.
Okay,
So the two metals never rub against each other.
metal with ceramic.
Metal, poly, metal.
Right. LDH, which is a large diameter head, COC, to achieve a greater range of motion, especially in younger people like Dr. Chauhan. So would this be the choice? With a greater range of motion. COC, sir.
So large diameter head.
COC.
Preference for a large diameter.
Especially in younger people like Dr. Chauhan, would you prefer this?
Yes.
Yes, he
But
said.
what is your number for large diameter, sir? There has to be a stop. I can't keep putting a large diameter. I have a lady. And most of the Indian females, now let me give you this. Most of the Indian females, their hip is only 46 or 48 mm. They come back at 38, the smallest, or on an average 44, 46, 48. They never get a large diameter, sir. उनको डाल ही नहीं सकते.
Why I said this was you could achieve a supraphysiological motion.
No, we achieve
With a large diameter.
Now we achieve all those movements with something called dual mobility. So in dual mobility, we achieve those movements which we were earlier not able to provide to the females. When they need more mobility than us, so we started using dual mobilities on them.
Okay. So let's talk a little about the super path.
Super paths.
super fat versus conventional versus the DAA. It's a direct anterior approach. Which is better amongst the three?
All are good.
No. Recent meta-analysis of 24 hours, it said probably the super path is probably the best because you need a minimal incision of just 3 inches. And this seems to be, the modality of choice today. I'm talking about super path, sir. Especially with the navigation. This has just been done in few centers, 5 centers in US and Canada. Are you doing this?
Why are
super path, sir?
Why are only 5 centers doing it?
This is as recent
I'll just tell you why.
just a month back.
Superpath came from Australia, sir, not from the US. Superpath is going above the trochanter levels and going in. The problem is, if I have to operate on myself, suppose for some reason, and what will I choose? I will choose something which is more predictable. Superpath has blind entry. Superpath has, when you put the femur, you can't see the femur, you're not seeing anything.
Yeah, but what are the advantages? No dislocation is needed here.
No dislocations?
Yes.
I think Dr.
I
think I must
Sir, I know my limitations. I am the last person to ask questions. Sir, my first and foremost comments to your presentation. Wonderful, sir. Keep it up. And we want another one. और वो जो एक फिजा चली हुई है, फिजा में बातें चल रही हैं आपके बारे में, हम चाहते हैं उससे आगे निकल जाए. Sir, autologous chondrocyte transplant, is it a choice for say mobility?
I have never used it in hips, but in knees, yes.
Sir, and sir, about increasing the height, Z plus T, earlier it was, theoretically it was that Z plus T करके muscle को बढ़ा सकते हो. Can you increase?
Hip में नहीं करते sir.
नहीं, hip की बात नहीं कर रहा हूँ. Height बढ़ाना.
Height के लिए, I don't.
Height के लिए long bones or it was earlier theoretically presented that you can increase the height by Z plus T.
No, it was popular in Russia. I think it's not.
It was there, sir.
Sir, मेरे को तो खुदा से डर लगता है.
मैं अपनी height के बारे में, although I'm not as young as Dr. Chauhan, but I want it. Sir, मेरा एक लास्ट सवाल ये है, मैं जब पार्क में घूमने जाता हूँ, मैं कई कुछ लेडीज को देखता हूँ जिनका लिम्फ है, मैं उनको जानता तो हूँ पर मैं इतना भी नहीं जानता कि उनको जाके रोकूँ या उनको कहूँ. And I at times feel that they have some problem in the neck, silence of the limbs. So will the soul be okay or they have to go through the rational
reason?
Yeah, we have to find where the problem is and then correct it. So I would like to send 2 of them. Thank you, sir.
The last question before we do the presentation. Yeah, the last question.
Dr. Ramneek, good evening. Excellent talk, but I'm a pediatrician, so my heart is with the kids. There are 2 problems in the babies which happen once they have avascular necrosis of the hip and Barthes disease. These are the 2 common problems which affect the hip joint. Do you have any experience with them in doing their TK, total replacement?
Sir, we don't do Barthes, which comes at around 10 years. We don't do hip replacements at that time. There are other options available. See, the aim in these hips is containment. So the word is containment. The hip needs to be in a socket when it is growing. Even if for next 2 years or 3 years, if the hip stays in a socket with any method, it will achieve some shape because of the loading and because of daily movements. And you only like to operate these when they come to a stage where there is skeletal maturity, ideally. And then if they get a painful arthritis, then you operate. If it is a painless, mobile hip, we still try not to operate.
Thank you so much, sir.
Thank you. Now let's finally, Mr. Chauhan.
Yeah.